Our knowledge and truth for a healthy living is a must. Here are the experts. Here are the facts. Here is what we testify to and speak. This is We Shop Talk.
Good afternoon, everybody, and welcome to episode 8 of We Shop Talk, presented to you by Sadika Family Physicians, and this is actually where we're recording this Sunday. So thanks so much for joining us. We are here this Sunday to talk about heart disease and heart-related concerns as it affects America and the Black community in particular. What's the state of affairs? Where are we? What does the future hold? We're here because February is American Heart Awareness Month. Yes, this is the month of March, but we think the issues still remain the same. We're here because every 33 seconds in America, somebody dies from a heart condition. Every 40 seconds, someone in America has a heart attack. So just think about that for a minute. In the next 1 hour, 120 Americans will die from some form of heart disease. The question is why? What do we do about it? This has been the case now for the last 50 years. Heart disease has remained the #1 cause of death in America, irrespective of race, gender, ethnicity, or socioeconomic status. What are we doing? In order to dive into this today, we have a distinguished panel of specialists that I'm so excited to introduce to you. This is going to be in 2 segments. The first segment will be focused primarily talking to the specialists to bring out their expertise. These are young specialist physicians who have been in practice jointly for over 90 years. They still look young and fresh. And on the second segment, we'll be talking to clients of ours who have testimonials to give about their journeys as relates to their heart condition. To my left is Dr. David Gbadebo. Dr. Gbadebo is a cardiologist here in Atlanta and also an electrophysiologist. A lot of his training was done at Emory University, Duke University, and Vanderbilt University. For those that know the Southeast very well, those are prestigious institutions. And he's been practicing here with East Atlanta cardiology for the last, in cardiology for the last 30 years. So we're so excited that you're joining us. He's well published and is a renowned international scholar too, and does lots of work too in other parts of the world, particularly Nigeria. And to my right is Dr. Bino Conjurman, who started out in Minnesota, University of Minnesota, did a lot of his training in the northeastern part of the country, and he's been here in Atlanta too. He's an intervention cardiologist and has headed Emory Hillandale and Emory Decatur Hospital in the cardiology division and also in the medicine division. He is now the chief of the endovascular specialist at the Atlanta Heart Specialist here in Atlanta. And his interest areas, of course, just spans across everything that you can do when it comes to cardiovascular disease. Dr. Conjurman, thanks so much for joining us.
Thank you for having me.
And joining us virtually from Kansas City is Dr. William Cooper. We're so proud that you're able to join us from Kansas City virtually. Let's first say he's a veteran. We thank you for your service to this country. He's a cardiothoracic surgeon and a health entrepreneur. He's the founder and chair of Cooper and Company Consulting and also Prime Health Services Group LLC. His interest area is so myriad. He's an author, but more importantly, as a physician and a concerned person, citizen, in terms of bringing difference to everyone that he touches. He's a decorated Army veteran, having served over 35 years in the United States Army Reserve and completed 4 tours of duty in support of the military operations around the world, where he retired in 2019. Again, he's well published. The title of his first book is called Heart Attack, Truth, Tragedy, Triumphs, which was released in 2016. Dr. Cooper, can you hear us? Thank you so much for joining us.
Yes, thank you so much. I hear you just well. Thank you so much.
Wonderful. So let's look at these numbers now. And we're going to come to you first, Dr. Gbadebo. 700,000 people die from heart disease every year in America. We did say that over 800,000 will have heart attacks this year in America. 600,000 of those will be first-timers. 200,000 will be second-time or recurrent, having a second heart attack. let's talk a little bit first about what the function of the heart is. What is exactly, how do you describe this to your patient? This is a small organ that's about 10 ounces that carries a lot of weight and function in the body. How do you describe the function of the heart to your patient, Dr. Gbadebo?
Yeah, well, good afternoon, everyone. It's a pleasure to be here, and thanks for the invitation to participate in this very, very needed program. So the heart is a mystical organ that everyone knows about, and we built a lot of emotions around our hearts in terms of, heartbreaks and heartfelt. It's a lot of words built around the heart. It is an essential part of the body. You can't live without it. So the function of the heart is to pump blood, to circulate blood, which carries oxygen to all the organ tissues of the body. Every organ in the body is dependent on getting blood flow, and particularly that comes with the oxygen for it to function properly. So it's a small organ. It does most of the work for the body, and it has to kind of keep a little bit of the blood for itself. And that goes into the heart by itself through tiny little vessels called the coronary arteries. And we're here today talking about what can go wrong when the heart itself is starved of blood. That little amount of blood that it needs for the coronaries to be able to function, when it gets impaired and you can't get the flow to the pump doesn't work. So the whole body is dependent on the heart for blood flow, but the heart is really the beginning point.
Thank you so much, Dr. Gbadebo. So to you, Dr. Congerman, so when we talk about cardiovascular disease, what exactly does that mean? And where does heart attack come in when you talk about cardiovascular disease in general?
Again, thank you for having me. To answer that question, there's a myriad of issues. So to continue with what Dr. Gbadebo has said, the heart functions as a pump. So there is a pump function. It has to supply its own blood supply to keep the pump going. And there are valves to make sure that blood doesn't flow backwards. So the number one heart disease, as you so eloquently put it, is coronary heart disease, where blockages in the arteries supplying to the pump has problems. They get blocked up, and the pump itself doesn't get enough blood supply, and it essentially has an injury, which is the heart attack. It can cause pain and so forth. That can happen as an acute event, which is where it suddenly happens, occludes, and you suddenly feel it. Can happen as a chronic event where it builds up over time. You feel it, you ignore it, thinking it's something else, but over a period of time, that vessel shuts down. And both of these, either the acute or the chronic event, can affect the function of the pump, where the pump cannot squeeze well. And we monitor that with something called your ejection fraction, where the pump cannot squeeze very well. And so that is one set of problems with impairing pump function. The other is cardiovascular diseases, the valves, where the valves are either tight or leaky, and this too can lead to where either the heart is working too hard to push blood out of the heart, or it can't. No matter how hard it works to push out, blood keeps pulling back, and it keeps getting bigger and bigger and bigger. And so that is another form of disease, so for the valve itself. But all of these ultimately lead to where the pump slowly starts failing, and what we call cardiomyopathy, where the pump cannot squeeze well, the pump gets dilated, and leads to something called congestive heart failure, and the long sequelae of that with the pump not functioning. Now, Dr. Gbadebo also works with the electrical function of the heart, where the pump itself has it controls its own function, where it has a timer and regulating that timer, and sometimes that gets dysregulated, and so you have to put a pacemaker and so forth. Sometimes it is a tachyarrhythmia, where the electricity itself causes a short circuit and starts making the pump go out of control. So there's ablations and so forth to control that as well, and so forth, or a defibrillator. When your pump is failed, you get a ventricular tachycardia, where we put in a defibrillator to control those events.
It's amazing, something so small
Yes.
with all of the functions and where things can go wrong. Not surprising, therefore, that we might find out that we're still kind of struggling to be on top of all of this. We're going to come to you, Dr. Cooper. What are those risk factors now that can put someone at risk for having cardiovascular disease, or in particular, a heart attack? I think there's so much data and information that is out there. What do you say about risk factors, Dr. Cooper, for our audience in terms of what can put one at risk for having a heart attack or just cardiovascular disease in general?
Yeah, so that's a good question. So, the first thing is that, there are those things that you can't necessarily modify, and you need to be aware of those. And so that goes into the category of a family history. None of us would probably change our families if we could. Quite frankly, we would probably stay right where we are. And then the fact that we're aging, we can't change our ethnicity, we can't change our environment. These are things that we called unmodifiable risk factors. And those things can be synergistic with the things that are modifiable risk factors for development of heart disease. And those things fall into the category of acquired conditions such as diabetes, high blood pressure, obesity, sleep apnea, chronic coronary or chronic heart arrhythmias that you sort of heard about here a little bit so far. So those things can sort of the things that we acquire over time. And then there are the things that we can really, really do something about in most cases, which is not smoke cigarettes. Cigarette smoking is a big risk factor for development of cardiovascular disease. Not exercising. We often encourage our patients to exercise and get out and be active, but the reality is not exercising is a major risk factor. And even not exercising up to the level that is going to support good cardiovascular health. And so all of those things can lead to chronic conditions, okay? Hypercholesterolemia, some acquired conditions related to that, and there are also some hereditary conditions related to that. So in general, cigarette smoking, a family history, obesity, hypercholesterolemia, high blood pressure, all those things put into one bucket are some of the major risk factors that we see. And not exercising are some of the things that we see that go into a big bucket of risk factors that contribute to the development of cardiovascular disease in all of its various forms.
Thank you so much, Dr. Cooper. And on that note, it's important, particularly for our audience, to also appreciate the fact that based on all the data and information that we have, Dr. Countryman, Dr. Gbadebo, 80% of heart attacks or cardiovascular disease is preventable. 80%. And of those, 1/3, to your point, Dr. Cooper, if 1/3 is due to smoking. So can you imagine the number of lives that can be changed or prevented if all of those factors that you mentioned, if we do things about them in terms of staying ready to be sure that we don't have to get ready. We're going to come to delve a little bit more into the preventive issues here. But Dr. Gbadebo, what are those symptoms that one should look out for or that might tell one that one may be having a heart attack? We know too, by the way, and I'd like you to comment on this too, that 20% of heart attacks could be silent.
Correct. So the typical symptoms of heart attack starts with basically a result of having decreased blood flow going through the coronary arteries. I brought a little schematic object here today to show the state of the coronary artery. If you can imagine, this is a vessel, circular vessel looking at the lumen, how blood flows into the coronary arteries of the heart. These are usually vessels surrounding the heart itself. You can see this is a very clear, wide open vessel. Blood flows through to the heart. This will be a normal function, normal feeling of a patient. As we age, one of the risk factors is aging, like Dr. Cooper mentioned. We start building up what they call fat streaks. The diet in the United States is very, very, very rich in fat and all the bad things. I mean, I can tell you, everybody in this room will have at least a little fatty streak. If you enjoy a nice barbecue chicken now and then, you will have a little. Hopefully, just a little. You can see, maybe not close enough, some yellowish fatty streaks that start to build up along the walls of the coronary artery, but it's still big enough to let flow. Most of the blood flow will go through unimpeded. So these are the early stages where patients actually don't have any symptoms. They can do most things without feeling a lick of chest pain or any kind of chest discomfort. As things start to grow, you start having more buildup of plaque that's narrowing the coronary artery. You start to see most of these patients at rest, they will feel fine. The first thing that goes away are the compensatory mechanisms that the heart has during exercise. Normally, the normal physiology is to increase the blood flow to the heart. All of those compensatory mechanisms start to decrease or be taken away. So it's usually people will start out feeling some chest pain or shortness of breath when they try to exert or do something what might be normally their routine activities, like going up the stairs in their home or carrying a bag of groceries from the garage. Things that don't normally cause them any discomfort start to take a lot of effort. So chest discomfort, shortness of breath, fatigue are the most typical symptoms that you have. You can have discomfort that is, again, off and on for some time. Again, most people, like Dr. Kunteman said, will have symptoms that they go to work every day and they usually can ignore and make other excuses not to get evaluated, unfortunately, until bad things start to happen. When you start building up blockages to a point where there's so much narrowing in the coronary, so much impaired blood flow as you see here, most of these people will have profound symptoms. Some of them will have profound symptoms at rest, and they are at the point when they are at the risk of having a heart attack or called acute coronary syndrome. Usually involves a disruption of the plaque, where there's a clot that completely blocks off flow to the rest of the artery, and usually comes with profound symptoms. In most patients, severe chest pain, 911. Some people, unfortunately, might die suddenly from that, but everybody doesn't experience chest pain the same way, or coronary artery disease or heart attack the same way. We do know that women particularly may present differently, usually fatigue. They may have symptoms that sounds like they're having hot flashes. Usually the peak time for women, they lag behind men in presenting for heart attacks for about 10 years, and usually falls at about the time when most women are beginning to approach menopause, so they can have sweaty brows, feeling of anxiety, restlessness, sleeplessness. Sometimes they perceive this as just not feeling well or just getting close to menopause, but it may be more ominous oftentimes that is due to coronary artery disease. Before I kind of go off on that note, we have what we call typical symptoms and atypical symptoms. You can have any pain or discomfort anywhere from your navel all the way up to your jaw. It could be coming from your heart. So because you are having indigestion or nausea, it could be your heart. Pain in the arms, neck, jaw, it could be your heart. So that people need to be very aware of. And it bears mentioning, as we speak about heart disease today, heart attacks today, a very big important point to make, I think, to recognize is that heart disease, heart attacks, is not just the only number one killer of men, but also of women. Mm-hmm. And what I find a lot in my practice, a lot of women are more concerned about breast cancer and things like that. Those are important too, but every woman, the average woman, is more likely to die of the same cause as a man, which is a heart attack, than breast cancer. So that's a take-home point for women to be aware.
Thank you so much, Dr. Gbadebo. And to your point, if you look at the causes of death in America today, cardiovascular disease or heart conditions is number one. Number two is cancer. Number three now is accidents, intentional or intentional accidents. Number four is COVID-19. And number five is lower respiratory disease like COPD for folks who smoke. And the list just goes on. But there is no question that, and then stroke is number five. If you look at those, clearly the heart has a big role to play along those lines. To you, Dr. Congerman, I want you to talk to us about how you diagnose heart attacks or cardiovascular disease. But before then, just to reflect on the average age of patients that you see in your practice that have these heart conditions. I want to stress that we know that 20% of people that have heart attacks are between ages 20 to 64. 1 in 5. So this is not just a condition that affects only seniors or folks who are over age 65. What is the average age that you see for men, for women? And then also to comment very quickly on how we diagnose cardiovascular disease or heart attacks in particular.
All right, so typically we see anything over 55, 60s, we start to see more and more. That's when the curve starts to spike and keeps going further higher up. But yes, I've taken care of people as young as in their 20s, low 30s. Usually they're, like Dr. Cooper mentioned, they have hereditary conditions and so forth, cholesterol issues that can do it. And sometimes even when all that is normal, genetically they're predisposed to plaque rupture, plaque buildup, and so forth that are giving them those kind of problems. As far as diagnosis goes, we have sort of the two separate ones. There's the chronic or stable disease where they come to our offices saying, hey, I'm having more and more trouble doing things. I'm having chest pains when I'm walking up the steps or lifting, so forth, or I'm having difficulty. Those subtle symptoms that Dr. Gbadebo went over, which was an exhaustive list, that's very good. And when you start having that, we have a testing process, starting with an EKG, then an echocardiogram to see if it's a heart pump is functioning, is there structural issues like valves and so forth, and a stress test. Usually putting you on a treadmill, making you on a treadmill to see EKG shifts. Some people cannot run on the stress test, but even if you do, you can compare it with an imaging study, like a nuclear scan or a PET scan, that can give us an idea of, hey, differential perfusion on a heart gives us an indicator of, hey, there's some issues of that. Despite all the testing, if there is still, if the story is valid enough, and we catch plenty of that in our practices, is that if the story is valid enough, you may still need to do what's called a coronary angiogram. Either a CT angiogram, where you send for a CAT scan that can look at the coronary arteries, or bring it to the cath lab and we go through either the groin or the wrist and put a catheter and shoot dye in the coronaries and see if there's any filling defects in those coronary arteries that we were talking about. Ultimately, that would be the gold standard. The question is, why don't we do that for everybody? It's an invasive procedure, it's a risk procedure, and if we did that to diagnose everybody, that's all we'd be doing. There wouldn't be a cardiology practice. The numbers are too staggering too if you do cath everybody that comes through the door. So we want to be able to risk stratify those chronic illnesses. Then there's the acute ones where people wake up in the middle of the night with chest pain, or I have a chest pain that just doesn't go away, it's getting worse. Nausea, abdominal symptoms that's getting worse. This is usually when you call 911 or come to the hospital, and there are certain patterns on the EKG that will show up that gives us the indication that you are having a myocardial infarction, what we call ST elevation maybe, or even non-ST elevation, whereby the EKG shows some ischemic variety.
changes.
Yeah, so the EKG, the electrical, is a photograph of what's going on at that time, and it gives us some picture of, hey, there's some changes in this EKG that's worrisome. Along with that, we do blood work. Now, if the EKG is suggestive of what we call an ST elevation MI right away, we activate the cath lab. That means you don't sit on that person. And so we have a nationwide, system-wide setup where even if it's the EMT at home comes and looks at you, call 911 and the EKG is there, they can call us at home and say, hey, this person needs to go to the cath lab. We don't ask questions. We take him. Maybe it's a blockage. Maybe, most often it's a blockage, and we fix it to relieve the symptoms. Sort of what we call aborting the infarct. If the EKG doesn't have that particular pattern of ST elevations, then we get lab work. And one of the things we look at is something called troponins, and there are cutoffs in that troponin markers where if it is significant enough or if it's rising, that we either start blood thinners and then, as a delayed strategy, take you to the cath lab to see where the blockages are and how we can go ahead and open up what's going on and address your issue problem. Maybe you need more, maybe you need an open heart surgery and so forth, or a stent will fix the problem. But that is the chronic and the chronic stable and acute varieties of addressing.
Thank you so much, Dr. Conjiman. And let's be clear, just to be again for our audience, we're talking about little blood vessels that take blood flow around the heart.
Yes.
When they get clogged or completely blocked because a plaque ruptures for so many different reasons, it clogs up that blood vessel, there's blood clot, and because blood flow to the other part of the heart is compromised, that heart muscle can literally die. And that is essentially what will cause most of these problems as it relates to the symptoms that have been eloquently described. Talking about treating heart conditions in America today, it's a $300 billion industry. $300 billion. Talking about the treatment, health services, medications, and loss of time from work or disability that comes from that. $300 billion that is spent annually on just health and health conditions. Dr. Cooper, to you, sir, we're still talking about EKGs. We've been talking about EKGs for many, many years. Is that still a very useful tool? And how have you seen the diagnosis of heart conditions evolve over the years? And where do you see us going? And for folks like us in primary care, very useful tool, EKG. I mean, you run that, it gives an idea. Is that the best that we can still offer patients now? Or where do you think we're headed?
We've come so far in terms of diagnosis. And so just so the audience understands, an EKG is literally just picking up the electrical activity of the heart. Okay, we put electrodes on the heart, and we have machinery and tools that can basically pick that up, and then it puts into a pattern that's consistent with the vast majority of normal individuals. So it's important, and this is one of the things that I hear a lot in my practice as a surgeon. When patients come to us, they say, well, I had an EKG and I had this test or I had that test and everything was okay. So each EKG is the way I consider it a very, very good screening tool in an ambulatory setting. What do I mean by that? When they come to your office, Dr. Akintobi, to be seen and evaluated, it's a great tool because what it can tell you is that, okay, the pattern of this EKG looks like, first and foremost, what it should like compared to large populations, but then secondarily to that, what does it look like compared to me? Meaning perhaps they came to see you a year prior or 2 years prior and they've got other EKGs and you could say, hey, you know what? This looks the same. It's basically comparable to what it should look like compared to large populations. But more importantly, there's been no change. All right. So that gives you a really good tool just as a basic screening tool. But the EKG becomes very, very important in scenarios that Dr. Conjiman and Dr. Badabayo mentioned earlier, when patients are now having symptoms or when they start having that pain or that fatigue or that shortness of breath, and they show up perhaps in an acute situation. What I mean by acute is, this forced me to go and get care. I either had to go to urgent care or in most cases to the emergency room because this is overwhelming for me. And then the EKG in those scenarios, having those kinds of symptoms, can be a little bit more specific. It can say, hey, is this something that's, much more serious? And Dr. Kungerman mentioned it in his commentary, the STEMI, or the heart attack. And in that case, it can be very, very good at diagnosing that, because it'll show elevations in portions of the tracing called the ST segment. So in those cases, it's very, very good. But it's important to understand for the patients and the patients listening to this, is that just because you had a normal EKG and it's outside the setting of an acute problem, meaning heart failure or a heart attack, acute coronary syndrome, or even a STEMI, doesn't necessarily mean you don't have heart disease. So you have to put the EKG from a diagnostic perspective into the proper context of why it was done in the first place. Very, very important point, okay? But then when you start talking about diagnosing it, okay, again, context means a lot, all right? The tools and the equipment that we have to make these diagnoses now has gotten so much more, I guess if you will, important and advanced. We can almost diagnose, quite frankly, blockages that both of the doctors have talked about earlier, in terms of diagnosing exactly where those blockages are with a CAT scan, a very, very sensitive, high-speed CAT scan that goes through the heart, all right? From a screening perspective, you see these mobile units on the corner now, or in a parking lot at a major office building. Oh, we want to bring you in and we want to do a CAT scan, a calcium score. That can give you information, all right? There are now tests that we can do that combine a functional test, meaning how is the heart functioning? Is it getting enough blood flow, with an anatomic look at the heart, that you can actually look inside and see what the structures are like. Those come in the forms of CT combined with PET scanning. It comes in the form of an MRI that can actually look at the valves on the inside of the heart. So we have a lot of diagnostic tools out there, but the important thing for our audience to understand is the context in which those tests were actually ordered, or what they're actually evaluating. Another very, 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 very helpful non-invasive test is just an ultrasound. And that's where we take the jelly and roll it around your heart, very similar to the same process that goes on when a woman is pregnant to look at the baby. We're looking at, or we're bouncing sound waves off the inside of the heart. So we can get a lot of information from those types of tests. So it's important to think about two things. Context, meaning, why is the test being ordered? What drove your doctor or drove you to even seek care for that? But then it also is very important to understand, what are we trying to find out about the heart when we order those tests? Are we trying to see how it's functioning? Are we trying to see, what the structures inside the heart look like? Or are we trying to evaluate the electrical system of the heart? All those things matter in terms of the entire diagnostic armamentarium for cardiovascular experts and specialists like myself and the other physicians on this panel.
Thank you so much, Dr. Cooper. And we're going to segue very quickly to talking about treatments. We have 3 specialists here that do different things. And that's exciting. I see the smile on Dr. Cooper's face to say that where were we in terms of treatment. But before then, I just want to encourage all our audience to check out heart.org. It lists very clearly the 8 essential things that is recommended by the American Heart Association that you can do today to start to reduce your risk. The first one we talked about, smoking. 1/3 of people that die from heart attack is from smoking. If you can prevent that, and it's not just smoking, it's vaping, it's e-cigarettes. They all fall under the same category. If you stay physically active, you walk, you exercise, start with 45 minutes, or you take 10,000 steps every day. If you watch your diet in such a way that you're focusing on mostly non-fatty foods, foods that have the mono and polysaturated fatty acids versus saturated or unsaturated, the risk is less. If you sleep 7 hours every day, the risk is less. If your cholesterol level is at a certain number, which your doctors will tell you, the risk is less. Diabetes and then high blood pressure. These are things that every individual can take control of starting today, because you can make that change. And the last is obesity in terms of weight management. These are 8 essential things listed under heart.org that talk about the list of 8 essential things that every individual today in America can focus on in terms of prevention of heart disease and heart attacks. Having said that, we said 80% is preventable. Let's talk about treatment, Dr. Gbadebo. How has that evolved over the years? Where are we now with treatment of heart attacks and heart disease in general? I'd like for you to comment on it from an electrophysiology standpoint and a cardiology standpoint, and Dr. Conjuman to talk about it from an intervention cardiology standpoint, and then Dr. William Cooper to talk about it from the cardiothoracic surgeon standpoint, who does these heart surgeries. So to you, Dr. Gbadebo.
All right. Hopefully not to confuse too much of our audience. I think Bez mentioned, the heart is a complicated organ. We are speaking about heart disease, can be exclusively coronary artery disease blockages that lead to heart attacks. I think that's the main focus.
Yes.
Well, imagine the heart is like a house. I tell my patients, we have valves like doors and windows that open and close and let blood in and out. There's electrical wiring that goes through the back walls that light up the house and make the heart beat. But the most common heart disease starts usually with blockages in the coronaries. Of course, if there's decreased blood flow to the house, everything is ultimately affected. So I will keep my comments purely to the topic at hand, which is the coronary blood flow, which is the most essential part of the heart that keeps every part of the heart working. If you don't have that, you're going to have all kinds of problems. So we've talked about EKGs, we've talked about the different kind of testing, and it's very important to understand that the most important test is really a clinical evaluation, more so than anything about being able to make sure you're getting your annual physical or whatever with your doctor, and early signals need to be followed. So it takes years and years for all these blockages to form to the point of crisis. Unfortunately, most of it gets ignored. People don't go to doctors, they don't have the visits. You have usually hypertension for many years, or diabetes for many years, or smoking for many years. You've been obese for many years, and nothing happens. They call this the silent killer. You're building up plaque, things are happening, and then one day you can't breathe, you're having chest pain. It's a long time coming. It didn't just start yesterday. So most importantly, having a physical examination regularly, having a provider assess you is important, because if you can, most importantly, prevent or manage your diabetes, manage your blood pressure. You see Dr. Akitobi, all of these are under control. Your risk of progression and developing into heart disease or coronary blockage is extremely low. Eating the right food, exercise 150 minutes a week. So all of these, best way to not do anything to not have a heart attack is to prevent a heart attack. So I would like to put a plug in for prevention. So none of the things we do are perfect. EKGs may be fine this year, but next year it may not be so fine. Again, you may be here, and you're fine, and you keep on doing what you're doing, the next time you're not so fine. It's like going through the airport. One day you go to the Dr. Akitobi and you get an EKG, it's being flagged at the security. Now they put you aside for a pat down. Unfortunately, some people don't make it that far. They wait and they just drop out. So I would like to put a strong plug in for managing your risk factors, all of the modifiable things that you can avoid, and making sure you are following up until that point of crisis. To avoid the crisis. Now, once you have been shown to have atherosclerotic disease or coronary disease or blockage in your coronary that's causing your problem, there are various options. It may be diffuse, small, but they're still causing problems. It may be just medical options available, medications to take, nitroglycerin to dilate, to make your blood flow bigger. Meanwhile, targeting all the risk factors, things that let plaque build up, high cholesterol, high sugar, targeting all those. That may be all you need to do. Sometimes you have severe blockage in a focal area that you can actually go to somebody like Dr. Kunjamini to have it opened up. They can open the blockage and put a stent and kind of get blood flow going back down that vessel. You can do that if it's amenable to that kind of therapy. In some situations, you have blockages in various areas or complex areas, particularly diabetics. They tend to have severe form of disease and complex disease that sometimes stents may help or not be so much. They may have to go to open heart bypass coronaries, where they take veins or arteries from the body to bypass, loop around areas of blockages, what Dr. Cooper does. So the first step is the angiogram, coronary arteriogram, looking at where the blockages are, and the strategies to establish or reestablish blood flow will depend on the complexity of the lesions and of the particular unique aspects of that patient that would decide whether they need angioplasty or whether they need an open heart bypass surgery.
Thank you so much, Dr. Gbadebo. So to be clear, if you have high blood pressure, your blood pressure should be 120/80 or less. If you have high cholesterol and you've not had a heart attack before, but want your LDL cholesterol to be less than 100, even if you're diabetic. If you've had a heart attack before, you want it to be less than 70. BMI for weight, you want it to be anywhere between, I would say even up to 27 is still okay. Yes, it's overweight, but there's still a lot of, the jury is still out on whether BMI is still the right way to go now, or what is called the BRI, Body Roundness Index. It's a new concept that is all coming together because a lot of people of color were not included in the studies when BMIs were being done. So big issue. But if you're diabetic too, you want your A1C to be less than 7. If you're non-diabetic, you want it to be less than 6. Physical activity. So these are direct numbers and statistics that people can really keep in mind and know that they work on those things, the risk will be less. But Dr. Conjurman, I mean, CATs have been around now for a little while. It's evolved. You want to take us down memory lane of how this has changed and what the future holds. What is a cath? What do you do in the cath lab?
All right.
When you get a patient.
So the whole point is to look at have an anatomy, or basically all the coronaries, see what it looks like. You're looking for how are the vessels? What is the patency of the vessels? It can deceive you in the sense of we can look at it, and as you can see, this will look really tight, and you'll have a whole series of vessels with this kind of blockage, and you can look at it and see whether it's normal. So the really tight ones show up, and what we do is we go with a catheter, which is basically a tube, and we go through your wrist artery or your groin artery, and we engage your coronaries, each one of the tubes. So
patients are asleep when you do this?
Yes, okay. Patients are asleep. They are sedated. Some request that they be, but most of the time they're sedated, and you don't need to be, when we say sedated, you don't need intubation or anything like that. It is usually twilight sleep where you are arousable. We want to be able to know if everything is okay, if you're having any chest pains or anything when this is going on. So we go in and go into the specific arteries. There's a left main system, which supplies the left anterior descending and left circumflex, which supplies most of the left side of your heart, and the right coronary system, which can supply the inferior and sometimes lateral portion of your heart. And we look at what is the patency of these vessels, and that is the cardiac catheterization. Sometimes, like I said, in the vessels that fool you into thinking, hey, there's blockage, but we're not sure. We have specific wires or imaging system inside the vessel where you can look at IVUS or so forth, the intravascular ultrasound. Dr. Cooper mentioned ultrasound, looking at the heart through the surface sound waves. You can look at from inside the heart. You can put it in right through the vessel and say, hey, what does it look like, this vessel? And I can say, oh, wow, through the ultrasound, it looks like there's a big plaque buildup. It's actually tighter than I thought it was, and there's a huge plaque buildup. I can put a wire through and see how well the blood flow went. So it's called a FFR, and see if these are vessels that are being compromised in flow, especially when you challenge the vessel. Or so that can tell us that, hey, in an exercise condition, it looks normal. It looks, but in an exercise situation, there's not enough blood going through that vessel, and we need to then, that particular regions that light up, we then do angioplasty, stenting, or if there's multiple anatomical locations.
What's angioplasty?
Angioplasty, in the old days, initially we put the wire, and across that we put a balloon, and we inflate the balloon and basically go through, and these vessels, we smash this plaque against the wall and open up the vessel to at least the portion of the normal part of the vessel. So we compare it to the normal and try to push it up as much as possible. We now for coronaries, that's complemented with stenting, which is almost 100% done along with that if possible, where you put a scaffold to stretch that and keep that vessel open. Because in the initial areas of angioplasty, there was always vessel collapse or dissections and so forth, and the vessel reoccludes. Mm-hmm. So the stenting prevents that from happening while this is going on.
And it now put medications in the stent now.
Correct, and that's the medications in the stent allows the stent to be patent for a longer period of time. Your body, all these medicines, all these technologies we have are only about 20, 30, 40, 50 years old. Mm-hmm. Our body has learned to have to survive over several hundred, several thousand years. So we have mechanisms in our body to fight when it sees something that is a foreign object, like a stent. So it tries to reocclude or repave that way or occlude faster, and there's mechanisms of it. We have medications on the stent to keep that open for a longer period of time, and we have medications that we give you after the procedure to keep your artery open for a longer period of time and stay on these blood thinners and statins for a longer period of time.
Okay. Go ahead.
So, and anatomically, if these are not, or if there's multivessel disease in diabetics, anatomically they're too much disease, or if there's what's called a left main disease, which is the main trunk supplying the left, then we have to ask for the help of Dr. Cooper to come in and bypass, as Dr. Badibo mentioned, about bypassing those vessels to get adequate blood flow to those distal portions, so that there's adequate blood supply going to the distal portion of the heart to keep everything working.
Thank you so much, Dr. Konjiman. So, Dr. Cooper, we're going to have you tell us what you do in 3 minutes, and how do you prep them, and what do you do to help them to recover in terms of doing what everybody knows as open heart surgery? At what point is that decision made?
Context very quickly. Yeah, so we typically see the patients in all of these categories from heart disease that are probably, and I don't want to say it that way because it sounds so morbid, but they're really there's no other options left. Because the reality is the options for treating heart disease from a non-surgical perspective have gotten so much better. I do want to plug this, and I want to say that it's important for the audience to understand that number one comment is that dying from heart-related conditions and the mortality related to it has gone down precipitously over the last 3-4 decades since I've been in medicine for 36 years now, okay? And that is because the treatments, that's number one. That includes medications, that includes interventions, and that Dr. Konjiman talked about, and the things that Dr. Badibo does from an electrophysiology and electrical system perspective, and also surgery. It includes and on top of that, the advances we've made in medical treatments, pills that you can take for these various conditions. Mm-hmm. So it's important to understand that. Second thing I want to say, this is not a either or in most circumstances. This is a both and in most circumstances, all of the above. It's medications, it's Dr. Badibo, it's Dr. Konjiman, and it's Dr. Cooper. Because what we do now, what we employ in these very complex situations is what we call a heart team approach. It's everybody contributing their level of expertise to get the best outcome. So, yes, heart surgery these days is, quite frankly, in a lot of ways, the bottom of the funnel in terms of you started here with prevention. You didn't do the things that Dr. Badibo talked about and Dr. Konjiman. You may have gone back and got a stent. You're diabetic. You're still smoking. You're obese. you're not eating right, and then all of a sudden now, all of those treatments have run their course, and you have to come to see us. So we tend to see people who have gone through the gamut or run the spectrum of all of those various, perhaps preventive measures, perhaps even therapeutic measures. But it's important to understand that it's again, it's not either or. It's usually, in most cases, it's all of the above. But what we see are those people who have blockages that have gotten very extensive. They've had prior stents, and Dr. Kunzelman says, "Hey, Coop, you know what? Gotta send this one for surgery." Okay, no problem. It's a heart valve issue. The heart's too leaky or too stenotic or blocked up, and we have to go in and actually either repair or replace those heart valves. Okay, it's situations where, quite frankly, in a lot of instances, the heart is completely worn out, and we have to put a device in to either temporarily replace the heart or basically permanently replace the heart. We call that destination therapy. So there's a number of things that, from a therapeutic perspective, that can be done on all of the various levels. What you really want to do is really, as Dr. Badibo said earlier, I think that's probably the most poignant part of this. You want to stay away from us. I mean, my next book is going to be called "Put Me Out of Business, Please." Those 8 things that you talked about, I mean, literally, 80% of this stuff is preventable, okay? If we would just take the steps to do the prevention. But the reality is, most people won't, and therefore you have myself and my colleagues, generous colleagues here, who can help you along the way. And in a lot of cases, get you back on track. I've had patients I've operated on and done bypass surgery who've run marathons, send me postcards from, the Eiffel Tower that they climbed. I mean, it's amazing. But again, we want to keep you away from us if we can, because the reality is, somebody mentioned it, or you may have mentioned it early in the top of the program about lost productivity. You don't want to spend your life coming to see me and Dr. Kunzelman and Dr. Badibo. You don't want to do that. I mean, you want to be out taking care, exploring life, exploring the world, going on walks with your wife and children and grandchildren. That's what we're here for. But we're here to help you if you happen to stray and need treatment for some of these conditions.
Quick question to you. How long does it take to do the bypass surgery if it's non-complicated? How many cases, for instance, can you do in a day?
Average time is about 3 hours.
Okay.
3 hours.
As we move into the next segment, because this is a conversation that can go on forever. It's been very, very lively. But before we kind of wind down on this first segment, and I want to get your comments, the three of you, starting with Dr. Badibo. The African Americans in America today have the highest percentage overall when it comes to death from heart disease and heart attacks. I think, again, for African Americans, it's about 22%. The rest of the population might be less than 20%, maybe 17% in some ethnicity, 15% in some others. Why is that?
Well, that's a million-dollar question, but well, there are various hypotheses and postulates that address that. I mean, so going back 100 years ago in this country, you can say that the data showed that African Americans actually had less coronary artery disease burden than we see now. At that time, it was below the white population. In sub-Saharan Africa, even today, coronary artery disease is less than you will see in the Western world. So is that part of the diet? Transplanted populations into different regions over time evolved to be part of the sort of the environment, and the risk level has been going up in the African American community over the past 5 decades. So we just accelerated beyond the average, I guess, white just about 20 years ago, and it's been going on rapidly. Some people say maybe there are too many fried chicken places around the neighborhood, too many burgers, where we don't do so much hard work, walking everywhere, everybody drives a car, and smoking has gotten so cheap, and unfortunately was promoted as a status symbol that a lot of people really adopted this bad habit in the community. Obesity, hypertension is a huge deal that is very prevalent and endemic in our communities. So a lot of these, again, it's not one thing, it's a lot of these factors, as much as you have together, I met people that are vegetarians and skinny with coronary artery disease that just run in the family because they have a special kind of cholesterol problem. It's new cholesterol just discovered about a decade ago called LP little a, that when you go and measure your cholesterol, everybody knows the good cholesterol, bad cholesterol, HDL, LDL. That's common in African Americans, but it was found that in people of Indian descent and African Americans, LPA may be even more relevant and important than the cholesterol we've been measuring for 6 decades. So why is that common in African Americans? We're still trying to figure that out. I have a research organization in my practice. We're one of the centers that are measuring LPA for free right now, hence at the end of this month. So there's a lot of factors. I think is partly nature and the genetics, as well as what we do to ourselves, inactivity, weight, and untreated hypertension. Again, the silent killer, a lot of people don't know they have it for years and years. Heart failure, almost every indices of cardiovascular disease is higher in the African community. So heart failure is just one of those results of that. So I don't think we can say for sure, but a lot of these factors probably play a role. Access to healthcare is another thing. So when people don't have a stable job or they don't have insurance and they have to work 2-3 jobs to put food on the table, they don't have time going to the doctors. And all of these play itself out in the shortened lifespan and increased mobility that we see, that they tend to present later when things are obviously serious and things you cannot ignore anymore. They're found at sicker states before when they finally show up. So I think it's a complex process of so many things that play a role to.
Thank you so much, Dr. Gbadebo. And also to you now, Dr. Konjima, I'm going to go to Dr. Cooper on the same question. I wanted to reflect a little bit on just what we now describe as the social determinants of health as contributing factors to this. Let us be clear. 25% of African Americans have a deep mistrust of the health industry. 25%. That is 1 in 4 African Americans have a deep distrust of doctors and the healthcare system. And we can go back and talk about the history as to why. I mean, we know all of that, starting with Tuskegee. It is real. When I see patients coming into the office at times and they're having chest pain, it's because a spouse, a friend has pushed them, and this has been going on for. So how do we address that? 1 in 4 of African Americans have a deep distrust. Health insurance that you mentioned in terms of access is real. Before Obamacare, we had about about 22% of African Americans didn't have health insurance in America. The most prosperous country on the face of the earth, 22%. That number dropped by 50% under Obamacare in the last 8 years. It is real. So some more people have access. Even outside of that, you have people who are underinsured and people that don't have insurance. You may have insurance, but you still don't have insurance. And so talking about social determinants of health as it relates to African Americans, I would like for you to hear your comments on that, Dr. Konjima, and then we'll wrap up with Dr. Cooper on this segment.
Dr. Gbadebo, we touched on all that, and you did too. Is number one is the affordability issue, as well as the trust issue. But as far as outreach and increasing awareness of there's still a lot of there's a huge lag behind it. Even the American Heart Association and all that, they're only starting now in the last decade or so to make a positive outreach to the communities and increase the awareness of heart risks, heart problems, and so forth.
The outcomes are better, very well documented, when you see a physician that looks like you and has walked in your path and understands your history and understands where you're headed and where you're coming from. How does that play into where we are, Dr. Cooper, with these numbers staggering against the Black community, just in terms of overall number of diagnoses? What say you, Dr. Cooper?
Yeah, I think it's somewhere around 4% of cardiologists and even much less than that, probably somewhere around 0.4% of cardiovascular surgeons in America that do what I do, but the data is pretty clear. But even at a much higher level, from primary care perspective, the disparities in terms of the number of people of color practicing and the people that they serve is still misaligned. So I do want to just comment on and I think that's very, very important because it plays into this whole idea of social determinants of health, where people are born, where they grow, where they live, where they work, where they age. Very, very important concept in terms of the influence of those factors on the outcomes, the incidence, and the prevalence of a lot of these chronic conditions, particularly heart disease. And the thing that's very telling is that you would think, if you were just to look at the surface, one of the most studied areas in terms of white poverty or white, not our lack of affluence in the white community has been Appalachia, and a lot of studies have been looked at Appalachia. But even in Appalachia, where you would consider it's a lot more density of white, poor populations, the outcomes from heart disease are even better in that population than they are for the average African American nationwide. So you say to yourself, wait a second, what you're saying to me is that someone who's poor, lives in an area where there's lower access, where there's lower insurance rates, where the incidence and prevalence of chronic conditions is higher, obesity, hypertension, high cholesterol, in a majority white population is still even better than African Americans in general across the entire nation. Yes, that's true. And so the fact of the matter is, there are things here that we don't necessarily understand. You touched on the trust factor. You touched on the factor of empathy and cultural competence. I can just tell you that there's a number of studies that talk about how people are treated, differentials in treatment in terms of how you look. Even if you come in and you walk into the emergency room and you look like me, and as a surgeon and a heart surgeon, highly educated and trained, it's very likely without you strip these labels off, I would be treated like other African Americans, which perhaps will not get me that other test or that higher level of care that I deserve. So it's as it's been alluded to here in this conversation, it's a multifactorial, but it starts with the social determinants of health. But for the African American community, I think the very important thing to understand about that is that you got to go a little bit deeper than just the idea of socioeconomic status and geography and those kinds of things. There's something a little bit more endemic here. And we haven't said it, but we have to acknowledge it, that racism in America is real, and it impacts a number of different things, and particularly when it comes to racism in healthcare and the differential in how people are treated when they present with various conditions such as heart disease. So I'll leave it right there.
Thank you so much. And I think on that note, it's so very well said. But let me just kind of end on this note as we go to segment 2. So many studies have been done. We know a lot that is working. There's a very fantastic study called the Cherish study out of New Orleans or Louisiana. There's another one called Enrich out of California, where at the barber shop, people get their blood pressures taken. And those who get their blood pressures taken oftentimes and come back, because you see the same barber I've had my barber for 30 years. You have the same hairstylist. If we can invest in things like that, where you can use that as a point of service care, it works. It's well documented. Or you use community-based initiatives or community faith-based initiatives in churches where people go to pray, and then we can check their blood pressures. We all have health ministries in all our churches and places of worship. It works. But we just have to be sure that we invest in efforts like that to meet people where they are, to meet people where they are invested in. Because at the end of the day, when we talk about health, for all our audience, it's not just about physical health, it's about emotional health, it's about spiritual health, it's about sexual health, it's about financial health, it's about psychological. So everything interplays one on top of the other. And if any one of these things is out of sync, of course, one is unhealthy. What we've talked about today, and I think very eloquently with our guests, with Dr. Cooper from Kansas City, Dr. Gbadebo here with me, and Dr. Conjuman, we've tried to focus on heart disease in America, with particular focus on heart attacks. This is it's an evolving subject. There's so many various layers that we might not even have been able to reach today. So thank you so much again for joining us on this first segment of today's episode 8 of We Shop Talk. We'll see you on the next segment, on the next go around. And to our specialist guests, we can't thank you enough. We're going to come knocking again when we have other health and health-related issues to talk about. We thank you for your time. We thank you for your expertise and your insights in this extremely very important topic that affects all of America, and just for bringing it to the forefront and letting us understand where things are and what else we need to do and where we head from here. Thank you so much.
Now that you heard the facts, apply the knowledge. Contact your doctor or healthcare specialist. Scan the QR code to provide more information on today's talk. See you on the next We Shop Talk.